Hey, welcome everyone to today's MaineMOM Echo. We're so happy to have all of you here. Elaine and I get to be together today for a little while. She's a short timer with us today. We'll until
We're not sure. I have to go. I have to go give legislative testimony at 1 o'clock. So I'm going to literally run across the street, but it will be a run. So, hi.
So welcome everyone. Mariah, if you want to pop that opening deck up, we can start right off because we're a little bit past the hour. Great. Okay. And let's just go through this first one. I'm just going to quickly really appreciate and thank our faculty for joining in our session. Let's go to the next slide. Today's didactic is going to focus on HCV in pregnant and postpartum folks. And then we're really appreciative to Northern Light. Bridget is going to bring a case forward for us. And just a reminder, Echo is participatory. So please, if you can, put your cameras on as much as you can during the session. Certainly if you're speaking, we would love your cameras on. And if you have any tech issues, pop that in chat to us. And we'll try to take care of you there. And if you don't mind, please popping your name and organization in the chat. That really helps us with attendance. Let's go to the next slide. And there will be CME survey following the session. And if you have any glitches with that, which a few folks have had, then just let us know and we'll make sure that you get that survey effectively. Let's go to the next slide, Mariah, please. Oh, very important. We're going to record the didactic, not the case presentation. And Mariah's already hit recording. Great. And I'm going to turn it over to Elaine.
Good afternoon, everybody. Super excited to see you all. This is Edith. I appreciate your flexibility with our creativity today. So I think one thing this is going to be pretty heavily focused on some of the materials that we've put together as the MaineMOM team. So what I really want to do is kind of talk you through how to think about treating hepatitis C virus in pregnant and postpartum individuals, and then also just orient you again to some of the resources that are out there. So to make it easier for you, frankly, as an on-the-ground clinician. And I think this has been, we've now, Tanisha could say for certain, but I think we're up to treating 6 or 7 postpartum patients at this point. So it's actually really pretty easy to do. I like to think if I can do it, anybody can do it. It's just a matter of getting kind of the workflow in your office and making sure that you're ordering the right labs, and also just trying to think really critically as you're doing it about, making sure that you get like the reflex lab and things like that. So you don't have to draw labs multiple times, because these are often folks who are either a hard stick or it's hard for them, can sometimes be triggering when they get lab draws. So it's just important to try to make it as patient friendly as you can. Next slide, please. So we're going to talk about evidence-based screening, identification, and then we're going to talk about treatment, and then we're going to talk about pregnancy implications. This is definitely one of those things that I think moms are often scared about, particularly if they're getting diagnosed right in pregnancy. Next slide, please. Okay, so we all know that our OUD rate in Maine is high and continues to be one of the highest in the nation. We do see that hepatitis C virus infection is correlated with opiate use disorder, as well as injection drug use. There's a range of estimates of how many women have it during pregnancy who have substance use disorders. We've definitely seen a climb. We were tracking our data when I was at Maine General, and we had an increase from probably 15, 20%, and it really kind of took off toward the end of kind of our sort of mid 2015 or so, that time frame, mid 2000s. And there's a nice study out there that really highlights this, that you see the prevalence of HCV in pregnant women, not with HCV, with OUD in the US increased from 87 per 1,000 births to 269, so over that 15-year period. So that was increased throughout the US during that time frame. We know that a risk-based approach to screening and diagnosis of HCV is inadequate. So, back along, we used to sort of screen folks who seemed like maybe they should be screened, which was never a very good measure. And I think we all know that folks who have a history of IV drug use may or may not want to disclose that. So it's something that's important to just be screening universally. And since 2021, ACOG, or American College of Obstetricians and Gynecologists, has recommended universal screening. It was earlier with some of the other organizations, but basically at this point, everybody should be screened for HCV during pregnancy, just like they're screened for HIV and all the other things that are sort of the routine screening for everyone. And I'm going to sort of sprinkle it throughout, but don't forget to order the reflex lab. So one thing that I see happen a lot is people will order the HCV antibody screen. So they'll look for basically the presence of antibodies to the virus in the blood, but they won't order the reflex lab. So that doesn't actually tell you if someone has an active HCV infection. So it's important that you order that, because then you can see their viral load kind of automatically, as opposed to having to send them back to the lab to get another draw, which they may even not go back to the lab. So there's a lot of reasons to order the reflex. Next slide, please. This is a paper that we wrote, just checking on the time here, that was looking at patients in the Maine health system. This was published, I think, in the Journal of Addiction Medicine. And it was looking at 916 patients with OUD during pregnancy. This was before universal screening was recommended. So there was 916 that should have really been screened if we did universal screening, but we only did 582. And as you see, the sort of numbers get smaller as it moves to the right. It really highlights that the tiny little percent on the end, the smallest bar, is the number that actually were treated for HCV. So we see that we had, basically 210 or so that were viremic, and we only ended up treating, I think it's 28. So it was a really small number before we were able to do this in our clinic. Next slide, please. So here's some information. I put the links up. So there's specifically the link to the HCV guide is the bottom one, and then the maine.gov DHHS one is the link to it's a website for all the information about MaineMOM. So there's a nice treatment guide that we're going to kind of walk through today. There's also some good stuff put out by both ACOG and the CDC, I think, are probably the best bits of information. So feel free to take a look at those as you wish. Next slide, please. So this is the algorithm that's, again, right on the MaineMOM website. So this is as you're thinking about taking care of folks who have HCV or who you're screening for HCV. Again, I say here, do the reflex lab for sure. So you do the HCV antibody screen. If it comes up negative, sorry, it's a little bit hard to read. That you may want to check the HCV RNA if exposures occurred in the last 6 months. So you may want to repeat this lab at some point, or just do the HCV RNA labs at some point in the near future if the patient says, geez, I have used IV drugs in the past 6 months. So it could be that they were infected, but it has not yet turned positive. But if there's, you do the antibody screen, it's negative, there's no further risk factors or nothing that requires ongoing intervention of any kind, you can just stop there. If you have the antibody screen come back positive, again, you want it to reflex to the HCV RNA, which is actually the viral load, which comes back as a number. So it could be 1,000 units, 100,000 units, something like that. If the HCV RNA is negative, that means they don't currently have the active HCV virus. So no current HCV infection. Again, if this is the first time this person's ever been checked, the guidance I've received is to check it again in 3 months, just to make sure that some folks who have HCV have kind of a sort of cyclical type picture to their viral load. So they may have a very low viral load and then it may go higher. So you'd want to check it again in 3 months. If you have somebody who has a positive antibody but a negative RNA, they may have already been treated for hepatitis C. So that's a great conversation to have. And then again, just talk about ongoing risk factors. Sorry, we're letting people in at the same time. We're getting creative. And then if they have a positive RNA, then they have active HCV, which requires further treatment or linkages to care. Next slide, please. So if you find out your patient is HCV positive, this is pregnancy management implications. So the maternal fetal medicine folks suggested getting baseline liver function tests, so baseline LFTs, just in case you're concerned that your patient goes on to develop preeclampsia, which the OB folks understand way better than I do. But basically, you want to be able to measure the difference in their liver function tests. So getting a baseline test will help them if they're concerned about preeclampsia down the road during the pregnancy. Discuss the risks of ongoing use of alcohol. Certainly, that's an important risk to be discussing anyway during pregnancy. Thinking about other infectious diseases that may be present depending on their situation. So it's important to have those conversations and to screen as appropriate. pretty much the rule of thumb is that you want to avoid as much sort of prolonged exposure to mom serum as possible. So there's a couple changes in what's recommended in terms of if you're doing ongoing testing. So amniocentesis over CVS sampling, avoiding prolonged rupture of membranes. One of the big ones is, minimizing the duration of fetal exposure to maternal fluids and blood. So that's those fetal scalp electrodes are definitely not recommended if mom has a hepatitis C. One thing that's a common question for patients is, do I need to deliver my baby in a different way? Like, do I have to have a C-section because I have HCV or something like that? And there's no reason to change the delivery plan based on hepatitis C. Breastfeeding is another super common question. So it's absolutely safe unless there's risk of blood exposure. So what we talk about with moms is, as long as things are going okay, that's breastfeed away. If they have cracked or bleeding nipples, like if something gets really irritated, we probably don't want them to breastfeed, but they could continue to pump as kind of that's healing, or just breastfeed off of one side. So it's just important to avoid any blood exposure. And then certainly if there's ongoing substance use, you'd be concerned about breastfeeding, but that's sort of separate from the Hep C. It's important to counsel that the HCV vertical transmission, so the risk of mom giving it to infant, is low, but it's real. So depending on the studies that you look at, it's about 5 to 10%. And infants should generally, there's kind of a changing rule of thumb about when to screen infants, but they should be screened by 18 months of age for hepatitis C. Consider these vaccinations if appropriate, and then you can consider assessing the severity of their liver function. I think your baseline LFTs will give you some information about that, and that's definitely a referral as needed. Next slide, please. Okay, so we put up a new information about provider talking points. So this is just to help you have conversations with your patients if they have hepatitis C. I think one of the things that's really nice, so to speak, is that we can treat kids now down to age 3. So when you talk to patients about needing to screen their infants, I mean, it's perfectly appropriate to wait till 18 months of age. The reason it's hard to do it beforehand is that the baby may still have some of the maternal antibodies in their blood. So you just don't want to confuse things. We don't want to make somebody worried that doesn't need to be worried. So that's why we generally recommend doing 18 months of age. And then they can be treated as young as 3 years old. So that, again, that's changed and that may continue to go down over time. But so, I really try to counsel moms that just, baby's not going to develop any chronic complications if they have it for less than 3 years, right? That's just not something we worry about, with hepatitis C, sort of ongoing complications of long-term positive antigens that they may go on to develop cirrhosis or liver cancer or something like that. But the baby is not going to develop any kind of complications in that first 3 years of life. It's important to screen previous biological children, particularly if they were not screened for HCV during that pregnancy, if there were risk factors present, and even if there weren't, probably it's just good practice to do that. We really encourage folks to be treated for HCV in the postpartum period. We'll talk a little bit about the breastfeeding piece. Reassure folks that it's appropriate for almost everyone to be treated for HCV. Even if they don't have symptoms. So you're really all about preventing future complications. Most women or most patients in general don't have symptoms of their HCV. So it's just you're preventing future complications. Significant advancements. I think this is where it's really changed dramatically. So when I first started treating HCV, I wasn't treating it back along because actually we weren't allowed to as general practitioners. You had to send folks through either gastroenterology or infectious disease. That has changed. But patients who used to be treated probably a decade ago, 15 years ago, it was a really difficult treatment. Like people were on medications for a long period of time. They often felt really yucky when they were taking it. It didn't always work. There were some people that would actually say to me, I wish I'd never treated my hepatitis C because it never got better afterward. That is like totally changed. Now we have patients who are on meds for like 8 weeks. They don't even notice it when they're on their medication. And then it works like almost 100% of the time. I mean, nothing's 100%, but it's like 95% plus. And so that's super exciting. So it's really easy to do. And I think one of the most important things is it makes moms feel good about themselves because they're successfully treating something that, it's yet another thing that they can kind of check off the list to sort of getting rid of that as they move forward in their recovery. Next slide, please. I don't remember what time to close this off. Okay. So treatment, there's a really nice algorithm, again, that's up on the website. We really want to treat folks, again, prevent future complications, prevent the risk of vertical transmission in further pregnancies. So if you have somebody who's in that postpartum window, no requirement for stability and substance use disorder treatment. So the old, again, back a decade ago, you had to have folks who had like no substance use in a 6-month period. There were all these very strict rules. Now we want to treat everybody with hepatitis C, even if there's some ongoing return to use. We want to reduce that risk. So what we can now do in primary care or OB clinics or really anywhere, again, this is a huge game changer, and this has only been a couple years. We're able to treat hepatitis C for folks who are eligible for simplified treatment. So who's eligible for simplified treatment? Honestly, most of your patients. So, because most of our women are young, they're pretty healthy generally, they don't have a lot of other chronic diseases. So they don't have cirrhosis if they've not been treated for HCV in the past. So that is, I have run into that, I think, once where somebody has been treated for HCV and then reacquired it. So that person would need to be referred. They're not pregnant. If they're not HIV or hepatitis B positive, they have no known liver cancer, and if they've had no previous liver transplantation. So again, this is most of your patients. Next slide, please. So there's a bunch of lab tests that you need to do in the past and do them. They have to be like sort of up to date within the last 6 months to get this is basically pulled directly from the MaineCare prior authorization. If you don't know how to calculate a FIB-4 score, that's totally fine. I don't either. You just Google FIB-4 score calculator and you put the numbers in and woo, it pops right out. And it gives you a number and it's super easy. And it's something like if it's less than 1.3, there's almost no chance of cirrhosis. If it's greater than 2.6, there's like a huge chance of cirrhosis, and that kind of in between is like unknown. So it's basically just a function of how healthy one's liver is. But you calculate that out, you do a CBC, you check their liver function, see how well their kidneys are working, you do the viral load. So that's important. And again, sometimes some of this stuff gets done at the postpartum period in general, some of it doesn't. So some of it you may have to order. What I've been trying to do, and I think it's been fairly effective, is that if there's some labs that I need to be able to treat, like I look prophylactically if I have a mom who's coming up at delivery, and she wants to get her hep C treated, I will look and see like, okay, we didn't order the genotype during pregnancy, so make sure that's ordered. So when she's on the inpatient unit delivering her baby and they've got an IV going anyway, you can have them draw those labs then. So you're kind of set up to treat postpartum. So you need the genotype, you need the RNA, you need to make sure they don't have hepatitis B, but again, that's a standard pregnancy screen. They say here serum pregnancy test. I don't do that. I do urine pregnancy tests. You can talk to the MaineCare people if you need something. I mean, I think you basically just don't want the patient to be pregnant. There are actually trials looking at treatment during pregnancy, so it's like not the end of the world if your patient becomes pregnant, but it's generally not recommended. And then there's these two really straightforward treatment options. From what I've talked to the infectious disease folks a couple times, as part of this process, they basically said your patients are pretty much always going to be on Mavorich unless there's something special. So I pretty much have never done anything other than that. The one thing to be aware of is that there are a lot of drug-drug interactions with these medications. So there's a nice you can literally click on it, put in the medications. But I think this is a place too where it's important to work closely with a pharmacy. So we've worked really closely with the Maine Medical Center pharmacy, and certainly I think anyone in Maine Health, I don't know if it's anyone in the state, but you can send the prescription down there. We do the prior authorization. They actually call the patient and do some education over the phone and even mail the patient the medication. I've had a couple of patients in residential facilities in a sober living environment where they've actually been able to have the medication mailed. So that's really cool and super helpful and all about patient care getting simpler. Next slide, please. I think I'm close to them. All right, so counseling, so testing to make sure that the HCV goes away. So after 12 weeks or more after completing the medication, you check for a sustained virologic response. So you basically look to see if there's any virus in the blood, and you only need to do that once if that comes back negative. The IG folks said if the ALT or some of the liver function tests were elevated prior to, you should check it again. And if it's still elevated, you may want to refer over. So keep in mind that when you treat hepatitis C, it prevents future complications. But if there's been any other damage to the liver, either from the hepatitis C or from fatty liver disease or some other thing, it doesn't like cure that which already happened. So if you have an elevated liver function test after treatment, they recommend referring over to GI for further evaluation. Remind the patients that they can contract HCV again. So that's really important. And they'll always have an HCV positive antibody. So they'll always have that antibody present. Confuses people all the time, right? I can't tell you the number of people I've seen who have like hepatitis C in their problem list, even though they only have a positive antibody because they've been treated. So it will confuse providers down the road. So I try to counsel patients about that. And patients, it's surprising how much. One thing I didn't anticipate was how much better they feel physically after treatment of hepatitis C. A lot of them say, geez, my skin was really itchy, or I was tired a lot. I felt fatigued, and so that seems to go away. The other thing they do is feel better psychologically. Like, again, this is another thing that they're just checking off the list. Like, I'm, not using substances. I'm being the mom I want to be. I've got rid of my hep C. Like, it's like kind of on that list of things that improves their sort of overall sense of well-being and efficacy. Next slide, please. I really like this one. This is the last one. So I pulled this from one of the papers that it's kind of like, when can you think about treatment? And the before pregnancy, I think, is one thing that we don't always think about. So if you're seeing patients in your office, they have hepatitis C, they're thinking about becoming pregnant maybe sometime in the near future, it's a conversation to have, like, hey, let's treat this so we don't even have to worry about the possibility of vertical transmission. So that's one that I don't always think of, and that's why I wanted to put this up. We're not currently treating HCV during pregnancy, during infancy for the children, or during breastfeeding. So that's not yet recommended. Patients will sometimes say, well, should I stop breastfeeding earlier so I can get treating the hepatitis C? And I discourage that. I say, breastfeed as long as you want to. That's great for your baby, because there's no risk of transmission really at that point, unless, again, the cracked or bleeding nipples that we talked about. So there's no reason to delay that, because you're also, it's just, the baby's not going to be treated for down the road, and there's no real risk after delivery anyway. So it's really after breastfeeding is complete and then in childhood. So I like this little slide because it kind of helps illustrate that. I think that's the last slide.
Yes, maybe. I'll take this
cool.
down.